Hello, in this video I am going to discuss the case of a 45-year-old male who has been married for 15 years and he has two children, and his current psychiatric problem is of major depressive disorder. Today he has come in with a problem that he is feeling suicidal because his wife has left him for somebody else and has taken the children with her. According to my assessment, the patient is actively suicidal with plan and intent, so I identify the situation as a crisis. Arthur Roberts has defined crisis as a period of psychological disequilibrium where the patient is experiencing disequilibrium as a result of a hazardous event which constitutes a significant problem that cannot be remedied by using familiar coping strategies. So if we analyze the components of a crisis, there is a precipitating event, which is an immensely stressful event, which makes up for a very aversive situation, and the patient is very vulnerable. So that's the second component. The role of the inherent vulnerability of the patient is involved, which can be a personality trait, issue that the person has. The third component is perception, which is a dysfunctional, irrational thinking, which can impact the way they process the event. The fourth part is the psychological symptoms, which may be strong emotions, anxiety, hopelessness, powerlessness. And then the next component is poor, faulty coping. So one's usual coping mechanism has failed here. So how does a provider act when a crisis has been identified? Albert R. Roberts has identified a framework called the 7-stage model of crisis prevention. It has 7 stages. The first is to conduct a thorough biopsychosocial crisis assessment, and here the most important thing in our situation is to assess the lethality and to confirm whether our client has initiated a suicidal attempt, whether they have any intention for self-harm. So it is important to get as much information from the client as possible by asking careful questions in an artful way rather than direct questioning. And for this we come to the second step, which means that you establish rapport with the patient by respecting and accepting the client, and to create a trustful relationship by assuming a non-judgmental attitude. The third stage of this model is to focus on the client's current problems which have precipitated the crisis. So taking these first 3 steps for our patient, we see that our patient is expressing suicidal ideation. So my first step is to complete a suicidal assessment tool like the Columbia Suicide Severity Rating Scale, or the CSSRS, which is recognized as a reliable and valid tool. It is also highly sensitive and specific for suicidal behavior. So this reveals that the patient is having thoughts of self-harming, ending one's life, which is a significant mental health issue. Here we talk about suicidal ideation and behavior. We assess both of them through yes or no responses. We see if it is an active suicidal thoughts, whether there is any method or plan without intent to act, then the active suicidal ideation with some intent to act and plan. And the third is active suicidal ideation with a specific plan and intent. So my assessment of the current patient reveals that he has active suicide ideation with an active intent and plan. He has a plan in hand, and he is determined to act on it. And it is also important at this point of time to see how frequent the ideation is, what is the duration, what is the controllability, what are the risk factors, deterrents, and reasons. So for our patient, we see that he has individual risk factors. He is a male, and according to Center for Disease Control and Prevention, the rate of suicide among men is 4 times higher than women. He also has a mental health disorder. He has depression since he was in his 20s. He has active substance use. He's drinking at least 4 packs a night. And the next risk factor is that he has a sense of hopelessness. Next, we talk about relationship risk factors. He has a loss of a significant relationship. It's a high conflict and violent relationship, and he's experiencing social isolation. Next, we can identify protective factors. We see that he expresses one reason for living, which is his children, but he is not very sure of whether they are going to continue to live with him. So that is also a question mark. So since this patient is actively suicidal with intent and plan, I identify the action plan to ensure safety by placing the patient in an inpatient facility with one-on-one observation and a thorough safety plan. So at this point of time, I will contact emergency services and inform them of the situation so that an appropriate plan is initiated for transport. By the time transport comes, I will try to take care of the next steps that are listed in the crisis identification model, which is to explore the feelings and emotions by actively listening, try to present an understanding relationship with the patient, and this would include active listening and reflecting his feelings. The next thing would be to explore any past coping strategies to help him out, to think of ways in which he can cope and to ensure his safety. The sixth step is implementation of an action plan, which we have already initiated, and we would also try to identify and contact supportive individuals or any referral sources at this point of time. The seventh step is follow-up, which would happen after he comes out of the hospital and maybe a month after the termination of the crisis, and try to work on his, at that point of time, we will counsel him, work on overall functioning, try to reflect on the precipitating event and the progress of treatment. So to conclude, we can state that we would be using the 7-stage model of crisis intervention by assessing the situation, identifying the current problem, initiating an action plan, which in this case would be to place the patient in an inpatient facility with one-on-one care and a safety plan. Thank you.